Good morning. Can you hear me?
Good morning, sir. We can hear you.
Okay, thank you. So today, in the first lecture, first 1 hour, uh, I have been asked to talk about portal hypertension and hepatic encephalopathy, two different topics. But I'll start off by showing you this diagram. You can see that there are four items or four entities in this diagram. There is cirrhosis, then there is portal hypertension, ascites, and then there's hepatic encephalopathy. Now you can see that these four circles or four entities, there is an overlapping area. So basically what it means is, for example, if you take cirrhosis and ascites, sometimes ascites is caused by cirrhosis. That's what the overlapping area means. Similarly, cirrhosis, portal hypertension, and ascites can also all be connected to each other. But at the same time, in those circles, there are also non-overlapping areas or outside areas. So what this means is you can have cirrhosis without the other three. And you can, for example, have ascites due to other causes, not portal hypertension or cirrhosis, but other causes. You can even have hepatic encephalopathy due to other causes without any cirrhosis. So these four entities are individual entities, but they frequently come together, happen together, because cirrhosis is the end stage of many liver diseases. So it's a common end stage, common scenario, just like chronic kidney disease or chronic heart failure or dementia and so on. And when cirrhosis happens, the other three are common complications: portal hypertension, ascites, and hepatic encephalopathy. Now, the reason why I'm showing you this in this way is that when you are studying, when you are learning, try to learn these four entities as separate entities. That's very important, because the reason why I say is, as an example, the investigation of portal hypertension is separate from the other three, or treatment of ascites is separate from the other three. So you should not treat ascites with the things that you use to treat portal hypertension, unless if ascites is because of portal hypertension. If it is in the overlapping area, that's okay. If it is if it is outside the overlapping area, then giving the portal hypertension treatment for those ascites patients would be wrong. So that is why we must learn these four conditions separately. So today, although I'm supposed to talk about only two circles, portal hypertension circle and hepatic encephalopathy circle, I will also address ascites to a little extent, not completely, but to some extent, because it's a little difficult to leave it out completely. But I'm not going to talk to you about cirrhosis today, because that will be far too much to talk in one lecture. And I hope that there is a separate lecture on cirrhosis for you all in your GI module. In any case, that will be too much to handle in one lecture. So I'm talking about three circles here. I'm trying to talk about the overlapping areas and the outside areas. So when I take say a particular circle, I will first talk about the individual circle, and I'll talk about the overlapping areas thereafter. Okay, so let's start talking about portal hypertension. Basically, if you look at the normal portal venous system, it's a very important and special system. A portal system or a portal venous system is a system that starts with capillaries and ends with capillaries. So one good example is the portal venous system. Another example is the blood flow from the hypothalamus to the pituitary. Another example is the blood flow from the efferent arterioles in the kidney to the renal convoluted tubules in the kidney. So they start with capillaries and end with capillaries. Now, the reason why this is important is because there's a problem with blood pressure and blood flow in these situations, because as you can imagine, these are all relatively low pressure systems, because already the arterial pressure has been used up in the capillaries for capillary function. And when you form the veins, and just without going into some other vein to the IVC or SVC, if you go into some other to supply other cells, then there's a, it has to be very well designed so that the low pressure can maintain the flow to the second set of capillaries also. Now, the reason why the portal venous system here is like that is it absorbs nutrients from the GI tract, from the intestines, and from the stomach and intestines. And then rather than going into the systemic circulation, they must go to the liver, and where these ingredients, these absorbed nutrients and all that is handled by the liver. And liver, as you know, is the major metabolic organ in the body. It makes sure that the ups and downs that happen with feeding does not cause ups and downs in the systemic circulation by acting as a kind of like a moderator. So the ups and downs, for example, if you take hyperglycemia and hypoglycemia, after a meal there is hyperglycemia, the liver makes sure it doesn't become hyperglycemic in the systemic circulation. And when the patient is fasting, the liver makes sure it doesn't become hypoglycemic either. So that is a sort of reason why the liver is situated in that position. But in addition to that, liver has other metabolic functions also. So the normal portal venous blood flow is about 1 to 1.2 liters per minute. Now that you can imagine that's a huge blood flow because the cardiac output is about 5 liters a minute. So this is about 20% of the cardiac output. That's a huge flow. It's coming from both the hepatic arteries and the portal. This is the portal venous blood flow coming from the gastric and the intestinal circulation, the splanchnic circulation. In addition to that, the liver gets blood from the hepatic artery also, which is coming straight from the arterial system. But the normal portal venous pressure is 5 to 12 millimeters mercury. So it's a low pressure system. So a lot of blood is flowing through a low pressure system. You must have heard about this irrigation channel called the Yodala. That is when blood water is taken for many kilometers at a very slow gradient, very gradual gradient. It's something similar to that. This is something similar to that. It has a huge flow, but very minimal pressure gradient. And the normal portal venous diameter is about 1.4 centimeters, less than 1.4 centimeters in a male and less than 1.3 in a female. Although in Sri Lankans, it's somewhat smaller than that, about 1.1 or 1.2. If you ask a radiologist during your appointment, they will tell you that they take the upper limit to be less than this in Sri Lankans because we are small made. So what are the causes of portal hypertension? The causes are categorized into pre-sinusoidal and post-sinusoidal. Now the sinusoid here is the sinusoid in the liver. You know, the liver, if you look at the microarchitecture, it has a special, after the capillaries, there's something called the liver sinusoid. That's a specialized venule. It is specialized because it has huge fenestrations or holes. And those huge fenestrations are required for the transport of macromolecules. That's why the sinusoids are important. So this is a very special place in the liver. The liver has to be able to take in macromolecules into the cell, and it also must be able to give macromolecules to the circulation. So for that, you must have this sinusoidal system, the huge holes. But if the pressure inside those huge holes is large, then the flow is going to be too much through the holes, and you are going to have kind of like a bleeding situation. So it's a very low pressure system with holes where the exudation of fluid is very gradual, very low, allowing macromolecules to go through. So the liver sinusoids are a very important structure in the body and for the liver, good liver function. And in fact, in a way, you could say that in cirrhosis of the liver, the main problem is this sinusoidal function is the thing that is most compromised. It starts there, but of course it affects the whole system. But its main starting point is changes to the architecture of the sinusoids. So when you say causes of portal hypertension, pre-sinusoidal would mean conditions which affect the system before the sinusoid. So it will be the splenic and intestinal and gastric capillaries, the portal veins, and then the portal vein the branches. Then it comes to the portal triad, and then onto the capillaries. All that is pre-sinusoidal. Then post-sinusoidal is on the other side of the venous side of the liver, the hepatic veins and the IVC. So, for example, causes of pre-sinusoidal include portal or splenic vein thrombosis due to various thrombophilias or infections causing what's called portal pyemia. It's the same thing that you call thrombophlebitis in other parts of the body. And also tumors in that region can cause thrombosis in those veins. And another important cause, which is fortunately not present in Sri Lanka, is schistosomiasis, which is a parasitic disease where it produces fibrosis of hepatic veins, I'm sorry, portal veins and inside the liver, but before the sinusoid. It's found in some countries like the Middle East and Japan and so on. Then post-sinusoidal causes include the Budd-Chiari syndrome, which is hepatic vein thrombosis, which can be due to trauma or thrombophilias or tumor invasion. Then there's a very special condition, which is very rare, called hepatic veno-occlusive disease, which is a very slow, progressive thrombosis and occlusion of hepatic veins, the smaller veins. And even conditions beyond the liver, like congestive cardiac failure or pericardial constriction, can cause high pressure and post-sinusoidal portal hypertension. Now, in cirrhosis of the liver, the obstruction is due to both pre and post-sinusoidal obstruction, but it is predominantly post-sinusoidal. And in pre-sinusoidal causes, hepatocellular function is better preserved because those architectural changes are before the liver cell. And therefore, in those conditions, the pre-sinusoidal conditions, the prognosis is better. Now, this is the main reason why we categorize it in that way. The other main reason, other good reason is the investigations are different and they are done in different manners. But it's very important when you see a patient with portal hypertension to find out whether the cause is pre or post sinusoidal, because if it is pre sinusoidal, the prognosis is better. Of course, you must also find the cause and treat that also. But anyway, the prognosis is determined mostly by whether it is pre or post sinusoidal. Okay, so what are the effects of portal hypertension? Well, there are 5 main effects, but I'll talk about only the first 4 because the fifth one is very, so far, not a big issue in medicine, so I won't touch that. I'll talk about only the first 4. First is congestion of abdominal viscera. Congestion means blood is dammed up or collected up due to the obstruction, giving rise to passive hyperemia. You would have to study that in pathology. And this congestion gives rise to congestive splenomegaly and hypersplenism, and portal gastropathy and duodenopathy. The second effect is portosystemic anastomoses and shunting of blood. That happens because of the congestion. It creates, there are normally anastomoses, and those anastomoses become enlarged, and that gives rise to a shunting of blood. So the GI tract blood, without going through the liver, enters the systemic circulation directly through those anastomoses. The third effect is ascites, that is accumulation of fluid in the peritoneal cavity. The fourth is liver cell dysfunction or hepatocellular failure, which can be either chronic or acute. And under other effects, I have said, I have listed portal pulmonary anastomosis and atheromatous change in the portal vein, but I won't be talking about that. I just mentioned to you so to complete the whole story, but actually they are not very important at undergraduate level. Okay, I'll take one by one the first 4. If I take the first one, the congestion of the viscera. So in the spleen, it causes splenomegaly due to excess blood, and that gives rise to hypersplenism because there is more cells in the spleen and all the splenic functions are accelerated. So cells are destroyed there. So therefore you get pancytopenia, especially thrombocytopenia. Usually by the time a patient develops cirrhosis, their platelet count has dropped to below about 120 or 100 into 10 to the power 9 per liter. In the upper GI tract, congestion produces portal gastropathy and duodenopathy, which can be seen by endoscopy. And it gives rise to chronic blood loss, giving rise to iron deficiency anemia, as well as sometimes acute blood loss, giving rise to upper GI bleeding, which manifests as hematemesis or melena. Let's talk about the portal systemic anastomosis, which happen because of the congestion. These are the sites, the lower esophagus and gastric fundus. That's the most famous site. That is where it's most commonly ruptures and gives rise to hematemesis and even death. It can also happen in the rectum, between the superior and inferior rectal arteries circulations. It can happen in the abdomen between the umbilical vessels and the epigastric vessels, giving rise to what's called caput medusae. Then it can happen inside the abdomen, the leonophrenic between the spleen and the diaphragm, leonocolic between the spleen and the colon, leonorenal between the spleen and the kidneys, and retroperitoneal tissues surrounding the duodenum. So that's a lot of anastomosis. And this is important for the surgeon. It's not very important for the physician, but it's important for the surgeon because when patients with cirrhosis undergo liver transplantation, unlike the kidney transplantation, in the kidney transplantation, it's technically easier because you just take the donor kidney and put it in the iliac fossa. When I say just take, it's not that very easy, but anyway, it's technically easier than the liver. In the liver transplantation, you must take the patient's own liver out, dissect the own liver out, and then in that liver bed, you have to put the donor liver or the donor liver lobe. Normally, it's only a lobe, not the full liver. So when the surgeon dissects that liver out, all these anastomoses start bleeding. So that's a very big problem for the surgeon. That's like a nightmare situation for the liver transplantation surgeon. They have much more difficult technical task compared to kidney transplantation because of this anastomosis that happen in the posterior abdominal wall. Then there can also be anastomosis between the left gastric vein and the pulmonary circulation. That's what gives rise to the portal pulmonary circulation anastomosis that I mentioned earlier briefly. So this is an appearance from an endoscopy, upper GI endoscopy. You are looking down the esophagus, and you can see the esophageal varices, like the tortuous enlarged veins. Now these ones, they can rupture and cause huge bleeding and hematemesis and kill the patient. So one thing that we do for patients with cirrhosis is do frequent upper GI endoscopies and detect these varices at an early stage. And there are various forms of treatment which the surgeons will talk to you about. And this is this is a photograph of the anterior abdominal wall. You can see the enlarged tortuous veins around the umbilicus. This is what we call caput medusae. Medusa is a Greek mythological character whose hair was made up of snakes. You can see a small photograph on the right upper end. So because this looks like the head of the Medusa because of the veins look like the snakes around Medusa's head. So it's called caput medusae. Caput means head. Medusae means of Medusa. Okay, so I'm going to change the topic now and go on to study or tell about ascites. Now I'm talking about ascites as an individual entity, first of all. I will later talk about ascites in connection with portal hypertension, the overlapping area. First, I'll talk about the entity. So ascites is the excess accumulation of fluid in the peritoneal cavity. And here also the causes can be divided into two groups of causes. First group is those due to local peritoneal disease, such as infections like tuberculosis or peritonitis, inflammation due to pancreatitis and so on, or tumors like secondary deposits from pelvic organs and so on. All these causes produce what you might call an exudate. So in those situations, it's a protein-rich fluid with abnormal cells like inflammatory cells or tumor cells. Now, actually, the word exudate is not very good. That is why I put it within brackets, because the word exudate and transudate is actually derived and used for pleural effusions, not for peritoneal effusions or ascites. There's a reason for that. The reason is pleural effusions are made only from one surface, the pleural surface. So you can categorize them into exudate and transudate based on the protein level alone. But ascites is not, that fluid is not formed from one surface. It is formed from the peritoneal surface. Yes, that's one part. But the other part is the liver surface. So what you find in ascites is a collection of, or is a mixture of the peritoneal fluid and the liver surface formed fluid. So we can't have the same protein concentration division that we have for exudate and transudate. That's why I put it in within brackets. So the first group of causes are the local peritoneal diseases such as infection, inflammation, and tumor. And the second is due to disturbances of Starling forces. And that's basically portal hypertension. And basically that's what we would call transudate in the case of the pleural effusions. It can happen with cirrhosis or without cirrhosis, as I said earlier with those circles. And if it happens with cirrhosis, it is also associated with hypoalbuminemia, and that also contributes to the acidic fluid formation, in addition to the portal hypertension. Now, if you can't use transudate and exudate, what classification can you use? You use this classification called the SAG, which is serum to acidic fluid albumin gradient. Serum is the S, acidic fluid is the A, albumin gradient. Now, remember, this is a gradient, not a ratio. So gradient is antara, that is x minus y. Not a ratio. Ratio is x divided by y. So how we get this gradient is you check the serum albumin and you check the acidic fluid albumin and you subtract acidic fluid albumin from the serum albumin. Not divide, subtract. So the difference is the gradient, not the ratio. So if the SAG is less than 1.1 grams per deciliter, it's due to local peritoneal disease. It's what you might think of as an exudate. But if it is equal to or more than 1.1 grams per deciliter, it's called portal hypertension. It's due to portal hypertension. So this is the value, the parameter which we use to separate those two causes, not transudate or exudate. So actually it is wrong to use the word transudate and exudate for acidic fluid. That's used for pleural effusion fluids. So for acidic fluid, we use the parameter SAG, serum to acidic fluid albumin gradient. Now let me talk about ascites in cirrhosis. So that is a high SAG ascites. That is to say, it's like a transudate. It's high. The portal, the SAG is equal to or more than 1.1 grams per deciliter. And the pathophysiology is, first of all, there's portal hypertension producing increased hydrostatic pressure inside the capillaries of the peritoneum. Secondly, in the case of cirrhosis, there's also hypoalbuminemia, therefore reduced colloid osmotic pressure inside the capillary in the peritoneum. And thirdly, there's a secondary hyperaldosteronism giving rise to salt and water retention. And that happens because the liver, in the case of cirrhosis, is unable to catabolize some hormones which produces a slight drop in the arterial pressure. It causes an arteriolar dilatation, producing arteriolar pressure to come a little low. And that's kind of, that's called, like, it's not a systemic blood pressure drop, it's a very slight drop. But there is a certain amount of blood pooling in the arterioles that gives rise to a reduction in the effective circulation volume. So therefore, the body goes into secondary hyperaldosteronism, so that the effective volume can be maintained by fluid retention. So this fluid retention gives rise to an expansion of the blood volume, and that maintains blood flow into the splanchnic circulation. So this is the way of accumulating fluid. But because of the disturbance in stalling force in the capillaries, this excess fluid, the fluid which is retained, always leaks out and collects up in the peritoneum, and therefore produces ascites. So the patient is retaining sodium, and therefore, if you take these patients and check their urinary sodium levels, it's very low. It's extremely low, because the patient is trying to retain all sodium and water in the body. But the retained sodium and water doesn't actually correct the effective volume reduction in the blood flow, but rather it leaks out into the peritoneum because of the disturbance in stalling forces produced by the portal hypertension and the hyperalbuminemia. And therefore, there's accumulation of fluid. So it's a high SAG ascites, and the protein concentration in the acidic fluid is very low. And there are no cells to be found there because there's no inflammation, no infection, no tumor in the peritoneum. Now, the low protein concentration is also very important because the peritoneal cavity has very few defenses. There are no cells to defend itself, just in the case of organisms. Now, sometimes organisms or bacteria from the bowel lumen can cross the bowel wall and come to the acidic fluid. That's called transmigration. It happens especially if there's ischemia to the bowel, but it happens normally in us also. And the defense against such bacteria is our complement levels, our complement proteins. They destroy those bacteria. But now in this acidic fluid, the problem is it has a very low protein concentration. Therefore, it also has very low complement levels. So our defense is gone now. So if bacteria enter this fluid through transmigration, it produces peritonitis very easily. So that's called spontaneous bacterial peritonitis. Why we call it spontaneous is because the transmigration is a spontaneous event. And a normal defense is complement, which is absent. Therefore, they get peritonitis. Of course, these patients can also get secondary bacterial peritonitis because of trauma to the bowel or ischemic injury or perforation or appendicitis or any of those causes, which can happen to anybody, can happen to people with cirrhosis and without cirrhosis. But that is different. That those are surgical causes. Sorry. Um, so, uh, so because of that, we must always keep in mind that peritonitis can be either spontaneous or secondary. That is either because of cirrhosis and transmigration and low protein concentration in the acidic fluid, or because of surgical complications like appendicitis or perforation and so on. Okay, the fourth is liver cell dysfunction, the fourth effect of cirrhosis and portal hypertension. So this is more severe if the cause is portal post-sinusoidal, as I said earlier. What are the manifestations? In the history, initially it's very vague with non-specific symptoms. I mentioned to you some of these yesterday in the chronic hepatitis talk. But later there's jaundice and hepatic encephalopathy. On physical examination, initially only a few minimal signs, but later there's what's called decompensation, giving rise to icterus and hepatic encephalopathy. Again, I mentioned that under chronic hepatitis yesterday. Investigations, you have initially increased AST, alkaline phosphatase, and bilirubin. And then later there's hypoalbuminemia, hyperglobulinemia, giving rise to what's called the reversal of the albumin-globulin ratio. Normally, in a healthy person, the albumin-globulin ratio is 1.5. Now here it is less than 1.5. Sometimes it's the other way about. That is to say, globulin by albumin ratio is 1.5. And then if there's acute decompensation, there can be coagulopathy and bleeding manifestations also. So I won't talk about number 5, the other manifestations. I'll just go to treatment of portal hypertension. The first thing to treat is the treatment of the cause. So that depends on what the cause is. If it is pre-sinusoidal, like thrombosis, we give anticoagulants. If it's schistosomiasis, we must give treatment for schistosomiasis and so on. For portal hypertension itself, there's medical therapy, first of all. The mainstay is beta adrenoceptor antagonists or beta blockers. We mainly use carvedilol, but if you don't have carvedilol, you can also use propranolol. But we must keep in mind this reduces the hemodynamic response to blood loss, acute blood loss. You know, when the patient becomes hypovolemic, they get tachycardia to compensate for the hypovolemia. And these patients will not have tachycardia because of beta blockers. So it's very important to keep that in mind, because if we rely on the pulse rate to diagnose acute blood loss, we will miss the blood loss, and the patient becomes hypotensive much earlier than those who are not on beta blockers. In the past, we used to give oral nitrates like ISMN, but now that is no longer used because clinical trials have shown that there is no survival advantage. If medical therapy is not effective enough, then we go on to surgical methods or interventional radiological methods to relieve the congestion. Now, a common thing we use in the NHS cell in Colombo is TIPS. TIPS stands for transjugular intrahepatic portosystemic shunt. So basically, we put a shunt between the portal vein and the hepatic vein through the liver, and we introduce it to the internal jugular vein. I will show you some photographs in a short while. And in addition to that, there are surgical methods also. Various artificial shunts can be created, like peritoneal venous shunts, what's called, as an example, the saphenous vein is connected to the peritoneal cavity, or renal shunts. These are not commonly done, but I think in Ragam Hospital, they do saphenous venous shunts fairly commonly, but not in most other hospitals. So this is a diagram showing you the tips, how it's done. You can see that from the jugular vein, the catheter is introduced through the internal jugular vein into the SVC, to the right atrium, to the IVC, and through the hepatic vein. And now it's inside the liver. And then along that guide wire continues to perforate the liver until it comes to a portal vein branch. Once that guide wire has gone from the hepatic vein branch through the liver tissue into a portal vein branch, then we use the guide wire to guide the shunt. You can see the shunt is like a small pipe. I use this arrow to show the shunt. This is the shunt. This is the guide wire which is sent through the internal jugular, SVC, right atrium, IVC, hepatic vein, and then through the liver tissue, it goes into the portal vein. And then along that, we push the shunt until it comes and lodges here. So when you lodge it there, one mouth is open to the portal vein, other mouth is open to the hepatic vein. And then you take the guide wire out, leaving the shunt in situ inside the liver. So it is sitting inside the liver organ, the liver tissue. One mouth is open to the portal vein, other mouth is open to the hepatic vein. So blood from the portal vein goes through the hepatic vein into this. So the pressure is relieved, congestion is relieved. So this is a ultrasound scan showing that. This is the shunt I was talking about. This white thing is a pipe, the shunt I'm talking about. Now here's one end. I think this must be the hepatic vein, and I think I'm not very sure. So this is the shunt seen in situ in the patient. So this is a good way to reduce the pressure. Immediately the patient's pressure is reduced, and sometimes and their prognosis is improved. In sense, like in some situations, this gives the patient an additional 2-3 years sometimes. So this is a very good thing to do. But unfortunately, there are two or three problems also. One problem is that all the substances absorbed from the GI tract will now go to systemic circulation without going to the liver. So, like it's just like anastomosis, like any other anastomosis. So it can predispose to hepatic encephalopathy. Second problem is it can become infected. And that's a very difficult thing to treat, because whenever there's a prosthesis in the body which is infected, that's a very difficult thing to treat. Usually we have to take out the prosthesis. And the third thing is this can become dislodged and stop functioning. It can also become thrombosed. So there are problems, but so it's not done always. It's not done if the patient is really unlikely to live long without it, when the options are limited. And in such patients, it does, if it works well, it does give the patient maybe 1 year, maybe 2-3 years more to live. And not only that, the quality of life is also improved in that one increased lifespan. This is done in our Colombo NHS cell, and it's, fairly successful. We have seen patients and we don't often see complications, although of course it may be seen by the other specialists. So now, how do you treat ascites in cirrhosis? So there are 3 stages. If the ascites is tense and the patient is uncomfortable, we must take some fluid out immediately, and that is for relief. That's called a therapeutic paracentesis. But if the patient is not uncomfortable, we try first-line therapy. The first is diet and bed rest. The diet we change to a low-salt diet, and the bed rest improves the diuresis that happens. Even without diuretics, it gives rise to a diuresis, because the venous pooling in the lower limbs is reabsorbed, and that gives rise to a better renal blood flow and loss of sodium and water in the urine. Next, we use diuretics. Basically, we use furosemide and spironolactone in special adjusted doses. We use furosemide 40 milligrams once a day and spironolactone 100 milligrams once a day, not BD or TDS, just once a day. The reason for this ratio is the hypokalemic effect of furosemide and the hyperkalemic effect of spironolactone are balanced by this ratio. And why once a day is because spironolactone half-life is prolonged in liver disease, and furosemide is a very brisk diuretic, so just once a day is enough. You can increase the dose gradually, maintaining the same ratio, and the maximum that you use is furosemide 160 and spironolactone 400. But there are complications like hypokalemia or hyperkalemia, hyponatremia, both of which can cause hepatic encephalopathy. And sometimes there can be dehydration and acute kidney injury. Now, if these things don't work, still the patient is getting ascites, then we call that diuretic resistant ascites. Now, that's a very important condition because the prognosis is actually very poor. So basically, it's time to talk about palliative care in those patients. There are treatments for that also. Again, you can try therapeutic paracentesis. Some people give albumin along with the paracentesis, some people don't. The reason why they give albumin is because when you take a lot of fluid out, it can cause hypovolemia and shock. And of course, you must also treat portal hypertension. Now, this is the kind of patient where the tips I mentioned earlier would become useful. Okay, let me go on to hepatic encephalopathy now. This is the second part of my talk today, in this 1 hour lecture. So again, I'm going back to the full circle of hepatic encephalopathy. I'm not talking about cirrhosis and all that. First, I'm talking about just hepatic encephalopathy by itself. And then later I'll talk about hepatic encephalopathy in cirrhosis and portal hypertension. So basically, this is a syndrome of neuropsychiatric dysfunction caused by portosystemic shunting. That's basically the meaning of the word. So you can see it's a syndrome. There's a collection of signs and symptoms. And the syndrome consists of neuropsychiatric problems, neurological problems and psychiatric problems. Both are there. And the reason for that is not an infection or anything, but portosystemic shunting. And this dysfunction can range from very subtle psychiatric manifestations like personality changes to deep coma. So there's a huge spectrum. There may or may not be any liver cell dysfunction, that's liver cell failure, but if there is, they usually have icterus and they have a much poorer prognosis. So those with hepatic encephalopathy and icterus have a poor prognosis. And the pathogenesis is that there's a production of various nitrogenous substances in the gut by bowel flora, bacteria, and these are absorbed into the GI tract, but they can bypass the liver because of the shunting, and they go straight to the systemic circulation. And then in the systemic circulation, they have effects on the neurotransmission in the brain, and the brain neurotransmission gives rise to this neuropsychiatric dysfunction. Now, from this pathogenesis, I can tell you two important things. Now, first is, I said that is because of portosystemic shunting. That is correct. However, you will see that even if there is no portosystemic shunting, if the liver cell is completely stopped functioning, even if the blood is going through the liver, but the liver cells are not functioning at all, you can still get the same problem. And then you are right, that can happen also. So although portosystemic shunting is part of the syndrome in the definition, there are sometimes cases where we are without shunting also. A previously normal liver and GI tract, if the liver completely shuts down, you get hepatic encephalopathy there also, because the blood is going through the liver all right, but it's not becoming detoxified by the liver. And the second thing I want to tell you from this pathophysiology is that you can see that the effect is on the neurotransmission in the brain. That is to say, there are various neurotransmitters in the brain, about GABA and acetylcholine and so many neurotransmitters. It is a disturbance of neurotransmission. It is not a structural disturbance. So as soon as you correct this chemical problem, the neurotransmission can come back to normal and the brain starts functioning again. Unlike, say, for example, strokes or hemorrhages or infections and inflammation or something like that, where, like even if you correct the thrombosis or whatever which caused a stroke, the brain is still structurally or is still anatomically abnormal. It won't come back to normal. But here, the brain is structurally normal, but functionally not normal. And there is potential to bring the brain back into good function by correcting the functional problem, the neurotransmission problem. So this is a very important situation. Hepatic encephalopathy is by itself, as far as the brain is concerned, it is treatable. But as far as the liver is concerned, it may be untreatable. So there are three types of hepatic encephalopathy, A, B, C. A is due to acute liver failure. Now, this is the example I told you earlier where there is no shunting and the liver suddenly shuts down due to acute disease, like severe acute hepatitis. You might remember I told you a story yesterday about day before yesterday about that young girl from Vallavaya who came with acute hepatic encephalopathy. She got acute hepatitis, and the mother went to get firewood, and she was playing with the younger brother and underwent physical exertion and the head to and all those things, and the liver failed, and she was unconscious, and she was brought to hospital. She had acute hepatic encephalopathy due to acute hepatitis, no shunt there, so it's a type A. And of course, fortunately, she recovered with full treatment. Type B is due to portosystemic shunting without any intrinsic liver disease. For example, pre-sinusoidal portal hypertension. And type C is due to cirrhosis. Now you can imagine that the type A has a very poor prognosis because the liver has completely failed acutely. Type B is pre-sinusoidal, so there's with a good liver, so the prognosis is better. And type C, again, they are shunting with a bad liver, that is sinusoidal or post-sinusoidal portal hypertension. So in that situation also, the prognosis is poor because liver cell recovery can be limited. So this is how you classify hepatic encephalopathy, type A, B, C. But there are other ways also. You can call it episodic and continuous, persistent or resistant, minimal or subclinical, and so on. There are other ways to describe it also. Now, if you look at type B and type C, in addition to shunting, in both conditions, they are shunting. In addition to shunting, there are precipitating factors also. So these are the list of those factors: dehydration, GI bleeding, constipation, excess dietary protein, urinary obstruction, then infections like spontaneous bacterial peritonitis, UTI, cellulitis, pneumonia. These are the common ones. Then drugs acting on the central nervous system, such as especially benzodiazepines and opioids, which you must avoid in these patients. Hypokalemia and hyponatremia, which can happen with, for example, diarrheal diseases. So you can both have hepatic encephalopathy with both constipation and diarrhea. Then renal failure, any surgery, even TIPS. Then superimposed liver injury, because these patients with cirrhosis they can also get acute hepatitis due to hepatitis A virus, for example. So any acute hepatitis, liver cell carcinoma, and of course when the liver cell mass has become reduced to extremely low levels, they get what's called terminal liver disease that also gives rise to hepatic encephalopathy and eventually death. So these are the precipitating factors. These must be there in addition to the shunting in types B and C. So when we are doctors who receive these patients with hepatic encephalopathy, is they are type B or type C, we must look for these precipitating factors and correct them, because otherwise they won't recover. Now there are grades of hepatic encephalopathy, grades 1 to 4. So 1 is mild, 2 is moderate, 3 is severe, and 4 is coma. And this staging is done looking at 4 parameters. First is level of consciousness. Second is intellectual function. Third is personality and behavior. And fourth is neuromuscular abnormalities. So now basically doctors are very good at the last one, checking for neuromuscular abnormalities. And they are very bad for looking at the first 3. Intellectual function and personality behavior, they are very difficult to pick up unless if they are gross. Best people to pick it out are the family members. So that's very important to keep in mind, because if you want to detect early hepatic encephalopathy, you must talk to family members. The patient won't know that they have hepatic encephalopathy. The family will notice hepatic encephalopathy. So you must talk to the family members and to take a history from them to look for the early features of intellectual function and personality and behavior dysfunctions. And also, you can, even before that happens, when you diagnose cirrhosis, for example, in a patient, you can educate the family to watch out for these features so that they can detect it earlier, because sometimes Unfortunately, they might not know that these are important features, and therefore they might not bring the patient to you. They might come at a later stage. So if the patient family is informed and educated, they can watch out for that and bring the patient earlier. Now you might wonder, why is it so important to detect it early? I mean, if you don't treat it, it's going to become more advanced, and then they will come to hospital anyway. Then you can treat it. Treatment is the same. Why do you want to detect it early? What's the big idea? Well, there are two reasons. One reason is that treatment may be easier in the early stages because you can correct the precipitating factor more easily. So they can be treated quickly and sent home more quickly. And there's a second important reason. That's a more important reason. That is, those who are having only subtle intellectual dysfunction and personality and behavior dysfunctions, they will be in society working like everybody else and making mistakes. Sometimes those mistakes are bad for them. They might make a bad investment decision, a bad calculation, which can be bad for them, can have social repercussions for them. Or sometimes they can, if they are operating machinery or driving a vehicle, they can make a mistake and have an accident which can injure either them or other people. So it has been clearly shown that people with early hepatic encephalopathy, with personality and behavior changes and intellectual functional changes only, they have more accidents. And they can even hurt other people, harm other people. So that is why it's important for us to be on the watch out for early stages, because you can prevent all those problems. Now let me just quickly go through these changes: stage 1, 2, 3, 4. You will see the early stages are very subtle. If you look at the mild stage, uh, the conscious level, they might have sleep inversion. They sleep during daytime, they are awake at night. Intellectual function, they will have shortened attention span and mildly impaired computation, like making mathematics, calculations. And with regard to personality and behavior, they must have a little bit of euphoria or a bit of depression or some irritability. Now, this is what the family can look out for. If you see the patient in these stages, you might see the famous, they might see a bit of a tremor, a slight muscle incoordination, and slight impaired handwriting. So now, as you can imagine, we never check these things in our patients in the hospital. So this is not easy because doctors sometimes don't even know about them. It can be easily missed. Then in the moderate stage or stage 2, conscious level, the patient is very lethargic with some mild disorientation or confusion. Now, these, of course, easy to pick up. Intellectually, they have amnesia, loss of memory, and grossly impaired computation. Behavior, they have overt personality changes or even inappropriate behavior. And on examination, they'll have slurred speech, flapping tremors, hyporeflexia, and ataxia when they walk. So that's easy to detect, moderate hepatic encephalopathy. Then the severe one is when they have, in the conscious level, they are either somnolent or sleeping all the time or having what's called semi-stupor. They can't compute. They may have paranoia and bizarre behaviors. And when you examine them, they'll have hyperreflexia, nystagmus, Babinski sign, clonus, and rigidity. And finally, they have coma, or they are unconscious. They can't function intellectually. There's no personality, and they may have dilated pupils, oppositernus, and coma on examination. So this is the gradual worsening of the hepatic encephalopathy. So here I have just shown them in time. The x-axis is the time, y-axis is the various features. I have got three triangles, a red one and a blue one. The red one is psychiatric manifestations. The blue is neurological manifestations. The reason why I wanted to show you is, you can see the 1 and 2 and 3 and 4. The reason why I want to show you is I just want you to appreciate one thing from this triangle, this diagram. And that one thing is the red triangle starts before the blue triangle. So psychiatric manifestations come first. Remember, I told you at the beginning, it's neuropsychiatric manifestations. But actually, psychiatric ones come first. Neurological ones come later. So this basically means if you want to pick them up in stage 1 or even 2, you must start looking for the psychiatric manifestations. And that basically means you must talk to the family. The neurological ones are the later ones. They are good for 3 and 4. So that is what I wanted to show you with this colored diagram. So principles of management of hepatic encephalopathy, the first thing is to identify and remove or treat precipitating factors. Second, diet and hydration. In the acute stage, we withhold dietary protein and correct dehydration, hypokalemia, hyponatremia, and zinc deficiency. On recovery, we can give a low protein diet, which is vegetable protein, with what are called keto analogs of branched chain amino acids. Pharmacotherapy, our mainstay is lactulose. We also use oral antibiotics to decontaminate the bowel. So usual ones are oral metronidazole and oral rifaximin. Then there are drugs that increase ammonia metabolism in the mitochondrion. They include intravenous L-ornithine, L-arginine, which we call LOLA. Then there's one called ornithine aspartate, L-acyl-carnitine, and sodium benzoate. All these things, of these, we have oral LOLA. We don't have IV LOLA, even in the private sector. I mean, sometimes it's available, but is generally available is oral LOLA. So if the patient is able to, or the family is able to bring some LOLA from outside, we always bring and give them the oral LOLA. But actually, if you look at the evidence is only for IV LOLA, but we believe that even oral LOLA works when we give it. Then if the patient has been on opioid and benzodiazepines, which has precipitated, that we can use antagonists. And even otherwise, sometimes we can use these antagonists to see if it helps, because sometimes the neurotransmission can be corrected to some extent. Zinc supplementation. And if there's coagulopathy, without overbleeding, we give vitamin K. We give it orally or IV. We don't give it intramuscularly because of the intramuscular bleeding that can happen. If there's overbleeding, we have to give fresh frozen plasma. Other measures are bowel cleansing, which is not done in Sri Lanka nowadays. In other countries, they do it through a colonoscopy. In Sri Lanka, we used to do what's called bowel washouts, which is a very dangerous procedure, which has been given up now. But if it is done through colonoscopy, that's called bowel cleansing. That's helpful, but difficult for us to organize actually. There are artificial liver support methods. There's one method called MAS, which is actually using the same hemodialysis machine, but with a different filter. And liver transplantation. All these three measures are actually not available in Sri Lanka, at least not widely available in Sri Lanka. Now, let me tell you a few things about lactulose, because that's a very commonly used medication in our wards, and you must have been taught this in pharmacology as well, but I just briefly tell that. Preferred route of administration in hepatic encephalopathy grade 1 and 2, we give it orally. 3 and 4, we give it as a retention enema. How to give it orally? We start with a dose of 30 ml 3 to 4 times a day, and titrate the dose to produce about 2 to 3 soft stools per day. Continuous use after recovery reduces recurrence of hepatic encephalopathy. So therefore, we send the patient home on these lactulose as well. However, be sure to check the sodium and potassium levels when the patient comes back to the clinic, because otherwise next time they get hepatic encephalopathy because of the hypokalemia. And the adverse effects are diarrhea, hypokalemia, gaseous distension, and abdominal pain and cramps. Don't give it orally if there are ascites or ileus, and try to avoid it orally if there's spontaneous peritonitis or stage 3 and 4 hepatic encephalopathy. And finally, in type A hepatic encephalopathy, which is one where the liver was originally normal and now having an acute liver disease, and where there's no shunting, in this particular type, cerebral edema plays an important role in pathogenesis. So therefore, these patients require ICU care with intracranial pressure monitoring, which is not available in Sri Lanka. And we keep the head end of the bed elevated by 30 degrees, which we can do in Sri Lanka, and induced hypothermia, and some pharmacological methods such as mannitol hypertonic saline to keep the target sodium between 145 and 155, and barbiturates to reduce cerebral metabolic function, and therefore, hopefully, they will not go into ischemia. N-acetylcysteine is also tried. They often get sepsis and seizures, so that must be corrected. And some causes have specific therapies, such as in the case of paracetamol overdose, you can use N-acetylcysteine. In the case of hepatitis B virus infection, we can give lamivudine, and mushroom poisoning is rare in Sri Lanka. Okay, so I've taken up the full hour. I can spend a few minutes if you want to answer any questions.